So it's a very really opportune moment. Today is the World Heart Day, and we have the eminent cardiologist of the town, Dr. Viveka Kumar. We are very proud of you, sir, to come and talk on this particular day on the heart failure from drugs to devices. I think, as Sushil said just now, the drugs are being hallmark of treatment of heart failure. Firstly, the assessing the heart failure, diagnosing heart failure in time, and treating appropriately. And sooner the better if we go on the devices to make them more comfortable. Dr. Viveka sir is known cardiologist, is an international cardiologist of next decade. He has a tremendous experience behind him. I will call him one of the excellent cardiologists of the round, and we are so proud to be associated with the Physician Forum of India. So we request you to carry on with your talk and enlighten us on how to be and when do we earliest start the devices to treat the heart failure to prevent any catastrophe with the patient or minimize the hospitalization and the treatment. Over to Viveka sir.
So, good evening, friends. At the outset, let me thank Dr. Mathur and Physician Forum of India Group. I hope you can see the slides. So, once the drugs have failed, as you would know, that heart failure is the final common pathway of all cardiovascular diseases. So, if the diseases are not treated well in time, the heart failure will set in, and we have different classification of the heart failure. We say, now for the FF, that is heart failure with preserved ejection fraction. By and large, we don't have much to offer in this. And then now recent data has suggested that, the SGLT2 inhibitors would be of significant use. The MR antagonists are there of some use. And ARNI did not show significant, it missed this significance level mark, but definitely numerically it did show some promise in that direction also. But when we say heart failure, we are talking mostly about heart failure with reduced ejection fraction and heart failure with mid-range ejection fraction. So if we see that, it is very apt that today on World Heart Day we say that, we should prevent heart from enlarging. So big heart is not good heart for cardiologists. So we need to try and decrease the size of the heart to normal. And beyond the drugs like ARNI, the 4 pillars of heart failure with reduced ejection fraction is ARNI, MRA, that is mineralocorticoid receptor antagonist, then the beta blockers and SGLT2 inhibitors. Then we can add on the, ivabradine and so on and so forth. So if the heart failure is something where the typical signs of heart failure would be there, that restlessness, central swelling, effort intolerance, elevated jugular venous pressure, pulmonary crackles, peripheral edema would be there. And it is caused, as I said, it is common final pathway of all cardiovascular diseases. So structural and functional cardiac abnormality would lead to numerically commonest cause is the, coronary artery disease, because the patients who get myocardial infarction and all, they would land into this. So there is a, but the other causes are what we call post-viral myocarditis. We have seen a lot of patients post-COVID also landing into the heart failure with reduced ejection fraction. So any kind of viral myocarditis can lead to this. And also the patients who have had, rheumatic heart disease, severe valvular disease, and the genetic, we call it familial dilated cardiomyopathy could also be there. And then, of course, the, post patients who are chronic diabetic, so diabetic cardiomyopathy, and also the patients who are having the, alcoholic cardiomyopathy and all would be there. So, as I said, definition of heart failure with preserved ejection fraction, the mid-range ejection fraction, and the reduced ejection fraction are the mainly distinguished. And the criteria is that, mid-range we take it 40% to 49%. Preserved ejection fraction is 50% or more than that. And then reduced ejection fraction is less than 40%. And the purpose of classifying this is that symptomatically, not only symptomatically, but prognostically, mortality and heart failure reduced hospitalization all is more, they behave in similar way. So before clinical symptoms becomes apparent, patient can present with asymptomatic structural and functional cardiac abnormalities. The recognition of these precursors is important because they are related to poor outcomes, and starting the treatment would be very important in these subset of patients. So if you can catch the patients in early age, stage, then the mortality can significantly be decreased. So diagnostic criteria, as I said, history, physical examination, and echocardiography. So echocardiography is very important tool. So we can look at the history of the patient if they had previous, heart attack or angioplasty or bypass surgery, history of, arterial hypertension. So hypertensive heart disease can also lead to end-stage, heart failure, exposure to cardiotoxic drugs or radiation. So we have oncology unit also. A lot of our, onco patients do come with heart failures, and that is related to the cardiotoxic chemotherapy and radiation therapy. Then these patients would have orthopnea, paroxysmal nocturnal dyspnea, where early morning they would be having, breathlessness, and they to get out of the bed. Physical examination would have, rail fractures all over the chest, bilateral ankle edema. And when we hear, most often than not, dilated heart, we would have the heart murmur of mitral regurgitation, jugular venous pressure dilatation would be there, and displaced, the heart would be enlarged with this shortened apical beat. And so assessment is by, biomarkers are very important. So we should be looking at natriuretic peptides routinely done in clinical practice. So NT-proBNP, like Paradigm HF trial, included more than 125 picogram per ml, or BNP more than 35. And if these things are high, so I think if we do the biomarkers, we would be taking the the test of post biomarkers. If they're high, then they must go for an echocardiography. And if the echocardiography is showing the ejection fraction as discussed previously, then we would get in once the biomarkers are positive, then the echo, and then based on echo, we can classify our patient into whether ejection fraction heart failure, reduced or mid-range accordingly. And if heart failure is confirmed, then we need to go to the treatment. So let's look at the guidelines, what the current guidelines say. And, so recommendations are that the patients who have got hypertension, it is recommended to start early to prevent the heart failure, and because that would prolong the half-life, then counseling and treatment. So prevention of these things should be important. So smoking cessation, alcohol intake should be, stopped. Empagliflozin should be considered in patients who are type 2 diabetes, and also those who are now recommendation are that in those patients who do not have diabetes, there also all type of heart failure can be treated at the time. So we can have, the heart failure treatment, the ejection fraction. Can somebody mute?
डॉक्टर वजीरानी, आप म्यूट करिए अपने आप को. डॉक्टर वजीरानी, म्यूट करिए. डॉक्टर वजीरानी,
कैन यू कॉल हिम, सर?
मैं कॉल करता हूँ. हाँ.
So, and today must see in that light that yes, if a discussion is taking place, it is for the Bharatiya Janata Party to disclose. I can surely tell you that the meeting between the Home Minister Amit Shah ji and
डॉक्टर पीके गुप्ता के भी फोन से आवाज आ रही है. डॉक्टर पीके गुप्ता, प्लीज.
Yeah, so I think if we see that the ACE inhibitors, ARPs and all is very important, but if we look at the beta blocker also, so these are what we call guideline addicted therapy. So they are recommended from the different guidelines based on the mortality benefit of these. And then implantable cardioverter defibrillator is recommended in patients where the patients are asymptomatic, but the ejection fraction is less than 30%, or patient has got asymptomatic non-ischemic dilated cardiomyopathy also, who have received optimal medical therapy but still have class 2 or more than that. So ICT therapies are effective in preventing bradycardia, correcting the potential lethal ventricular arrhythmias, and also that can be treated, and that can, so as you would know that the patients who have got heart here, there is almost 20% annual risk of sudden cardiac death. So they benefit from that also. So the average, longevity is increased in this group. So if you look at the guidelines also, those patients, they also say that who are the patients who are requiring ICD. So the patient who has ejection fraction less than 35%, dilated cardiomyopathy, ischemic heart disease patients, if they have got the post-MI patient more than 40 days have passed after the MI, so that the mortality benefit will be there. So, and CRT would be considered if the patient has got criteria for CRT, which will come later. So the Pharmacological Procedure Devices Management is an expert European Society consensus document. Says that one may consider not to implant an ICD in patients with non-ischemic heart failure with reduced ejection fraction who have, who are in class 3 or 4. So if the patient has got class 3 and 4, then the risk of sudden cardiac death is significantly lower because the mortality can be high in these, and sudden cardiac arrhythmia would be there in CKD patient also. So if you look at the guideline, for class 2 to class 4, you need ACE inhibitor, beta blocker, MRA antagonist, and they are really helpful. Now we have got new MRA apart from spironolactone and other molecules. We would have, Venlafaxine, the trial is going on. We are also part of that. So that will be a revolution in that. So therapeutic agents for patients with symptomatic heart failure and reduced ejection fraction, as I said, this is the guideline mediated therapy that we can add them ACE or ARB or ARB. We can give them, Ivabradine, and we should need and evaluate the patients of optimal medical therapy. Then evaluate for CRT, and those patients who have got resistance symptoms, we should consider despite CRT. Then they would be the candidate for that particular assist device or heart transplant, that kind of thing. So if you see the patients who would need, cardiac dysynchrony is there. So patient whose ejection fraction is less than 30%, QRS duration and dysynchrony both have been identified as the predictor of sudden cardiac death. So we need to look at how wide the QRS is, and if it is LVB morphology, it is more the reason to, the patient would benefit for cardiac from the resynchronization therapy. So CRT can improve the ventricular contractility function, reverse the ventricular remodeling, sustain improvements in ejection fraction, increase blood pressure with CRT can also be seen. So this was a video, but I think it's not playing. I'll just show. So based on these data, the guidelines says that CRT is recommended for symptomatic patient with heart failure in sinus rhythm and QRS duration more than 150 milliseconds and LVP QRS morphology with LVF of less than 35% despite optimal medical therapy. So it's a very important thing that patients should be receiving optimal medical therapy. And in non-LVV, also in wider QRS, if the QRS is more than 150 milliseconds, then also we can offer them CRT therapy. But remember, we need to give them, and those patients who have got, LV dysfunction, but they would need pacing, so they are also ejection fraction less than 40%. We should not be giving dual chamber pacemaker. We should rather giving them a cardiac resynchronization therapy. So few examples like this: a patient who had hypertrophic cardiomyopathy, non-obstructive, and then gradually he kept on deteriorating and went into dilatory phase, and there the ejection fraction dropped to 20%, and he needed, you will see, the QRS was wide. So this is the angiogram, and then, what additional we can do. So based on the guideline of, 2016 ESC guideline, and so this is, class 2B indication. So in this kind of situation, what we did is that this is what the CRT was given. So we did a CRT in this patient because there was a, left bundle branch morphology, QRS was wide, and this is the ideal position of CRT wire. So the patient's condition improved. You can see the QRS became narrower after pacing. So another patient who had 50-year-old male, LVD of giddiness and easy fatigability. You can see ECG, there was complete AV dissociation, so complete heart block kind of thing was there, and this is something which needed so CRT in this situation where the patient has complete heart block but low EF, as I said, the recommendation is that we should not give them dual chamber pacemaker or single chamber pacemaker. Rather, we should go for cardiac resynchronization therapy, which will improve the. So either we can give cardiac resynchronization therapy with defibrillator or with CRT pacing. So this is another patient where you can see the complete heart block, baseline left heart block. So this is again a candidate where we should be giving cardiac resynchronization with pacing. And so when we are upgrading the pacemaker, there also is a dual chamber pacemaker, but pacemaker induced LV dysfunction and happened. So here we should give a CRT. So we gave this patient a cardiac resynchronization therapy on upgradation. So this is again a patient where post EPI his LV dysfunction developed. So he needed in long term this cardiac resynchronization therapy so that he benefits. So if you continue to do patients, moderate LV dysfunction with RV pacing, eventually over the years they develop, drop in ejection fraction and can cause, further symptom deterioration. So there we need to upgrade whenever the battery finishes, or if the patient becomes symptomatic, we can upgrade to cardiac resynchronization therapy so that they benefit from that. So these are the guidelines which suggest that, the same guidelines are working here also. Now those patients who have got atrial fibrillation, there also we can give cardiac resynchronization therapy provided we do the AV nodal ablation. So this is an algorithm that the patients who have got QRS duration of more than 120 milliseconds, but there we can consider CRT. In patient that has got atrial fibrillation, we can do AV node ablation, and because for CRT functioning you need more than 95% of the compulsive biventricular pacing. And if the QRS duration is less than that, then obviously we should be avoiding cardiac resynchronization therapy in these group of patients. So now there is a new term of pacing, we call it field bundle pacing, where we can take advantage of the normal conduction system so that the QRS is narrow. So this is also called poor man CRT because you are not causing RV pacing and resulting into LV dysfunction. So these are the studies which have shown that the hot CRT or left bundle pacing will improve the outcome. So these are the data in that direction, and now this is something which is quite prevalent, and we have been using it on a regular basis. Only downside of this is the His bundle we trace here, but downside is that the tonic threshold increase is very high in His bundle pacing, so it's not yet a very mature technology, but eventually things will move in that direction. So this is an ECG of hot CRT patient, and it takes advantage that the patient gets benefit not only of the left ventricular pacing, CS, but also the His bundle pacing so that the QRS remains narrow. So this is again a data that suggests that His bundle pacing with CRT optimization causes maximum degree of cardiac synchrony and causes more benefit in our patients. So it is now coming in the guidelines also that we can do hot CRT in patients who, or those patients who have got LV dysfunction, there we can do this bundle branch pacing. So to conclude, I would say that friends, the cardiac resynchronization therapy is the ultimate for heart failure, but we can start from the drug. We have to diagnose the patient early, start with the guideline medicated optimal therapy, and if that doesn't work, then we can go to ICD and CRT based on the indication. And beyond that, the patients would benefit from the surgical intervention like left ventricular assist device or heart transplant. So thank you very much for your kind attention. Over to Dr. Chauhan and Dr. Mathur for further.
Thank you, sir, for a very nice talk on the use of devices, and you have highlighted the importance of the heart failure. How early we can diagnose by history, clinical examination, and echocardiography role is very important. Once we diagnose the heart failure, we start therapy as you advise, medical therapy, but nonetheless, the importance of devices has to be come in play, and earlier the better. So it is very nice update on the devices, how and when to use. Thank you, sir. And now is open for the questions from the delegates who are attending.
Sir, Dr. Mathur, with your permission, can I ask
questions first?
Because, sir. Sir, very nice talk, sir. But I was reminded of Punjab Congress High Command. There was no command. There were so many interruptions between the talk. So it could have been muted for everyone, as it is done
Because
usually.
it has been asked for, but people are not sensitive to that. Anyway, that's not. We are
Mr. High.
apologizing to everybody.
Sir, High Command बंद कर सकते हैं. Anyway,
I know.
Sir, my first question is, just we heard about renal transplant is your kidney transplant is your wife, and dialysis is your girlfriend. So in this context, so the cardiac transplant is of course the wife, and devices are, I can say, Sally, and drugs are girlfriend. Is it like that? Dr. Viveka, sir.
No, so I would say that for the heart failure, there are multiple girlfriends.
Okay. Yeah, definitely. Sir, girlfriend means many. Girlfriend itself means many. Dialysis are many. So, the permanent treatment is wife. That is the final. वो जन्म का साथ होता है ना वो तो सर. जन्म का साथ तो.
We not been able to identify who is not muted. Can we ask the host to mute? Sorry for that.
Yeah, High Command has to come, sir. Sir,
Yes, I think
this was on a lighter sense, sir. So just to enlighten my friends, that kidney transplant is the final treatment, heart transplant is the final treatment, and in between comes the devices, and for many years, till that we arrange, we get the final treatment, we have the drugs to follow. So, about ARNI and SGLT2, these are the newer additions to our armamentarium for the drugs. So have they changed our need for the devices to some extent?
yes. So you're very right that these newer therapies have the power to reduce the hospitalization by 42% almost, and then the sudden cardiac death also goes down. Ejection fraction starts improving. So basically, these are very good and wonderful drugs. So the need for devices, I would say, has come down. And also, let me tell you that even if you look at the survey recently, the cardiac resynchronization pacemaker implant has gone down, though the CRTD, that is defibrillator uses have been static or gone marginally high. But you're right that these newer medication has really improved the outcome in our patients. So remember, we need to give our patient best of the both worlds. So if you give the data from those who have had devices, so all these major trials had devices, patient also to the tune of 14 to 20%, and they did also benefit from these medications. So I think the time is that we need to give maximum to this, because if you look at the data of mortality, almost 50% of the patient will not survive more than 5 years. So that's a very, very dark reality. So we should give everything possible, especially those who are younger patients. We should throw everything, whatever we have available.
Sir, clear my doubt that if a patient with preserved ejection fraction is not treated well.
Dr. Viveka, sir.
Yeah.
Sir, Dr. Chauhan, only two more questions. Sir, am I audible?
Yes, sir.
Yeah.
I can hear you.
If a patient of preserved ejection fraction is not treated well, so does it mean that he will end up into reduced ejection fraction?
Yeah, so I think it's not that they will go into reduced ejection fraction, but the problem is that the mortality and morbidity of preserved ejection fraction is almost same. So the preserved ejection fraction patient also, the mortality of 5 years is almost similar, almost 40% people do not survive up to 5 years. You can imagine that the doctors will keep on saying that the heart is perfectly okay, your ejection fraction is well maintained. But if they have got the element of that failure with preserved ejection fraction, they would not die because of the deterioration into ejection fraction, but as a consequence of the heart failure, they would be dying.
Sir, does 3D echo add up in any way to the management of the heart failure, or it doesn't have much say in the management of heart failure, like tissue, perfusion and all that? Does it matter?
So tissue Doppler and all would show, but 3D would not. 3D is only for structural diseases. So
for the valves and all that. Sir, does prolonged bradycardia also need to damage to the myocardium, because vascularization is it's ischemia again. In tachycardia it's ischemia, and in prolonged bradycardia also it is ischemia because heart rate is too less. So does it add to more chances of heart failure if bradycardia is prolonged?
Yeah, so I think the diastolic heart failure becomes more pronounced in bradycardic patients, and those who have got heart failure with reduced ejection fraction, they also do not tolerate bradycardia much. So the tachycardia is also equally bad. So those patients who have got prolonged tachycardia, what we call tachycardiomyopathy, the ejection fraction may go down further. So you're right that the cardiac arrhythmia, either it is brady or trachy, that makes patient worsening even more.
My last half question, sir. What is the status of stem cells in the heart failure? Are they in the pipeline or it's just a gimmick?
So as yet, because of the neo-revascularization and potentiating more cardiac arrhythmia, the stem cell therapy has not really taken off in heart failure. So still it is I would say, deep into the pipeline, far from seeing the end of the tunnel.
Thank you so much, sir.
Dr. Viveka sir, first of all, I want to congratulate you. It's an honor to speak to you on the World Heart Day and to hear from you on such an important topic. I have some very simple questions to answer. Sir, you said the 4 pillars of heart failure management. And then you very deftly went onto the field of devices, sir. My question is, once we put a device to the patient, does the need for oral medications come down? I mean, drugs like MRA, drugs like Diagnostic, drugs like Arning, do the need for these drugs come?
Yes, I think that's a very good question. So that's what I was telling briefly, that even if we have put the devices, the absolute need comes down. Obviously, the biggest advantage of putting devices is that the need for diuretic and those medications which is only for symptomatic benefit comes down significantly. We stop at digitalis, we stop the diuretic or the dose. Having said that, other life-saving devices, because remember the ejection fraction does not improve in a day or 2 or 6 to 8 months, or it's a lifelong process. So these medications, so if you give the advantage of the device alone, then the overall outcome may not be as much better as it is with the device plus with drugs. So there are 3 arms: device plus the drug, and device alone, and no device, no drug. So obviously those who do not have no drugs, no device, they do the worst. Those who have got device plus the medication, they do better off. So answering your question, that the risk of the patient becomes much more tolerant to these medications, and these medications will help in cardiac remodeling further on. So definitely the combination of these, what we call pillars of the modern heart failure medication, should be continued even if the patient has got the device, so that there's no harm in getting their ejection fraction improved to almost near normal, because then you don't have to give diuretic, you don't have to give digitalis, you don't have to, and the risk of sudden cardiac death will also be lesser. The device delivery, that is cardiac, defibrillation and all, would be lesser because arrhythmias will be lesser. So I think that there is no recommendation to stop these drugs. So if the need be, these drugs can temporarily be stopped, but it's not an absolute indication to stop these drugs.
Sir, there has been a lot of talk about SGLT2 inhibitors being effective in preserved ejection fraction, and the data is now out, as we know. Sir, what about the other pillars of treatment like MRA and ARNIs? What is their effect on heart failure in the preserved ejection fraction? So your comment?
Yeah, so I think if we look at the data from the Emperor Preserve and the DAPA Preserve data that clearly showed that SGLT2 inhibitor is the drug which is working in that direction. That is beneficial, statistically significant. MRA antagonist was the only drug before this data came that it is helpful in this situation. But the other molecule like ARNI that numerically showed benefit, but it did not reach statistical significance, but FDA has given it approval to be used in that situation also. And so I think all these pillars are working in that direction. So I think we should be using the same molecule like SGLT2 inhibitor, ARNI, the MRA antagonist in heart failure with preserved ejection fraction also. Instead of beta blocker, symptomatic benefit for cardiac relaxation is with the calcium channel blocker. So instead of beta blocker, we tend to use diltiazem or verapamil in those situations.
Sir, you mentioned about the introduction of devices in a case of heart failure, and in patients failure should be. Can you hear me, sir? Can you hear me, sir?
Yeah. Yes.
So, what should be our approach? Should we start motivating our patients for devices as soon as NYHA 2, sir, rather than waiting actually for NYHA 4? Because most of the irreversible changes in the myocardium would happen by that time.
Yes, I think all the data are very good if we start the therapy early, so whether it is drugs or the devices. So I think by NYHA class 2 or more, so if you see the indication wise, if the patient is class 2 or more, then we should motivate them for devices. And remember, we need to give at least 3 months of, optimal medical therapy. And if the patient is still class 2 symptomatic, then we should offer them devices. So you're right that, earlier the better, but with the trial of guideline medicated therapy, so that therapy has to be given. And if the patient remains to be class 2 or more, then we should offer them devices.
Sir, just one last question from me, and I think the message for everyone, sir, who is on board right now. Sir, with everything coming in with such wonderful molecules for heart failure and such wonderful devices, are we just changing the quality of life, or we are actually changing the quantity of life as well?
Yeah, so that's a very good question. So if you see the quantity of life, that is also extended, and numerically there is almost 62% increase in longevity with device alone. There is almost 32% increase in the longevity with this drug, the MRA. So mortality is going down. So annual attrition rate goes down. So effectively, the overall longevity of these patients increase. Having said that, it does not help beyond the life expectancy.
Hello.
So don't expect that.
कल दिखा दो आकर.
So I would say that it increases not only the quality of life improvement, but also the quantity of life for longevity.
Thank you very much for wonderfully answering the question, sir. Over to Dr. Mathur, sir, and other questions from other members.
Dr. Chauhan, one question.
Yeah, go ahead, sir.
Dr. Podar, go ahead.
So, Dr. Viveka sir, if a patient is on beta blocker, ARNI, SGLT2 inhibitor, and if he develops low BP, so which medicine you will stop? Maybe diuretic also, because all medicines are given in heart failure. So, if he develops low BP.
Yes, I think we would better, first of all, stop the diuretic, then nitrates, and then, even the beta blockers. So ARNI would be the last thing to be stopped, but it's the things which do not improve the survival, those things should be stopped first. So you are right that the diuretic and all should be stopped, unless the patient condition is such that we can't stop that.
And sir, also, if I may add. with your permission, it is volemic. Patient is not hypovolemic because most of the times the patient is not. There are instructions from everyone, from Dr. Viveka to write to the junior nursing staff that you have to drink only 1 liter of water, including everything. So at times we overdo it, and therefore it's very important to make sure that the patient is euvolemic.
That's important. Very important. Yeah.
Dr. Mathur, sir.
Yeah.
Dr. Mathur?
Is there any more questions? Yeah, please.
Yeah, Dr. Mathur?
Yeah.
Dr. Viveka, is there any age restriction for use of Arni? Suppose somebody has a low ejection fraction of 92, 94-year-old man, and if his kidney function is 1.1, 1.2 of creatinine, is there any restriction, age restriction for Arni?
No, sir. To answer is that it is there is no age restriction because it's going to benefit in all the age groups. Though if you look at the trials, they did not include any patient which was more than 90 years, but theoretically it should work in them also.
Sir, with permission of the chair and with permission of Dr. Viveka, as Dr. Chauhan has very rightly said that if a person is not hypovolemic, this is to be ruled out. And the heart rate also, I think if heart rate is too high, we should not stop beta blocker also. Because if heart rate is already too high, it will be having heart rate itself as a negative effect. What you say, sir?
Yeah, that's very right. So heart rate is also very important factor, and that is a predictor of adverse outcomes. So we should be mindful of that.
I think
Yes, Dr. Viveka, did you say that instead of beta blocker in preserved ejection fraction, we should use calcium channel blockers like diltiazem and all?
Yeah, so the preserved ejection fraction where the diastolic dysfunction is there on echocardiography, the calcium channel blockers have been shown to be better agent for diastolic relaxation. So on echo, if the diastolic dysfunction is grade 2 or more, then we should use.
Okay. Thank you.
I think thank you everybody, and thank you. Since there are no other questions, I'd like to thank Dr. Viveka for brought out all the points that early diagnosis of heart failure, appropriate medical therapy at the time, and then introduction of the devices, sooner the better, they would say, prevent any complication or sudden cardiac death. So it is a very well presented, sir, and very well answered questions been asked from the forum. I'd like to once again thank everybody for joining us. And sorry, Dr. Kalra, for the intervention in between, which we have no control. And thank you, Doctor. Thank you, Viveka, sir.
Okay.